And the interesting thing, and I think for the primary care world who's probably not as savvy, how do I do these two? You forget about the GLP-1 receptor component and you just let the titration occur with the basal insulin product like we would anyway. And so Vivian, when you talk to your patients, because this is still relatively new in our practices, do you find that explanation helps them understand how to use the medication?
Yes, it does. And the major problem that occurs, as in this particular patient, is the fact that they've got to down titrate from where they are on what is failing. So this particular patient, it is probably relatively easy since your patient is already on both components and is doing reasonably well, so may not need much up titration. You could use either of the agents at a sort of halfway dose of 30 or 25 and up titrate back to that 45, 46 fairly quickly, and the patient should be able to tolerate it. But if suppose your patient was taking only insulin and was not controlled and taking 45 units, going back down to 30 or 25 and then back up titrating would be limiting because you may need more than 50 or 60 units. So in that case, you would not be able to use such a combination. But for the patient you described earlier, I think you would go a long way to improving the patient's adherence by using this fixed ratio combination, going from 3 injections a day to 1 injection a day. And I can tell you from my discussions with all my patients, or if I were in that position, I would certainly prefer 1 injection a day.
Right. I agree with you. And the only thing that I do with some of my patients, as you would hear, is if you picked Ideg-Lira, then certainly at bedtime is fine. If you wanted to pick Iglar-Lixi, you would have to get into the habit of using that in the morning instead of at bedtime. And that would be one thing that most patients are willing to do. And you would still titrate based on the fasting glucose. And you're right, this takes you down from 3 separate injections a day, plus the timing of a short-acting GLP-1 30 minutes before a meal, which can be problematic, which is why a lot of patients, if they're going out, they'll miss that evening dose. So you've gone from 3 injections a day down to 1. The other thing that I see here that I would do is I'd combine the valsartan hydrochlorothiazide into 1 pill and decrease at least by 1 pill the pill burden that the patient has. So we have some options for this patient, even though they're at goal, to try to address their number one concern, which is adherence to treatment. And so again, when we get the patient say, what are you interested in? I'm interested in an easier regimen. It's our job to try to figure that out for them.
Yes, I would agree with you there. I again get back to the caveat of the dose limitation. If this patient was for some reason already on over 50 units of insulin, I would in that case take away the exenatide and use it once weekly, as going from 21 injections a week to 8 injections a week, as opposed to if you use this fixed ratio, it would be 7. So it's not that different.
Right.
But I think this combination is here to stay. It is not currently indicated as the first-line injectable in the United States by the FDA, but in Europe it is available. So if you think about it, it's very attractive to be using 2 injectable drugs as 1 injection when oral agents fail. And there are studies ongoing to address this, and hopefully we will be using that sometime in the future.
You're right, Vivian, and I think that is the number one use in Europe is after orals. This is the first injectable. So I think the message is stay tuned. Maybe we'll have a change in heart of the FDA sometime soon.